Hello, I'd like to talk about the SDL titled Hyperlipidemia. But before I do, I would like to take the time to talk about lipid transportation throughout the body and to give you a brief overview of this process because it's very multifactorial and it's a complex signaling pathway. So a lipid is basically a molecule that's not soluble in water. It could be soluble in a lot of organic solvents, but it won't be soluble in water. So to transport lipids throughout the blood, we need to package them in these very specific lipid-friendly vehicles called lipoproteins. Now, some lipids are amphipathic, meaning that one end of them does play nice with water. And these are the lipids that we use to make membranes. There are also free fatty acids, which may or may not have a polar component to it. A saturated fatty acid is a chain of nothing but carbons and hydrogens, and an unsaturated fatty acid has a double bond in it. And you could have one or two or three double bonds, and each double bond will give the fatty acid a degree of rotation and thus mobility. So saturated fatty acids are solids at room temperature, and unsaturated fatty acids are liquids. They're mobile, they're fluids because they have more degrees of mobility built into their structure. A triglyceride is going to be 3 free fatty acids pasted onto a glycerol 3-carbon sugar backbone with 3 separate ester linkages, and the ester is the carbon-oxygen-carbon sequence of bonds, and you have to esterify a fatty acid anytime you want to store it onto something, and then you have to deesterify it anytime you want to mobilize it and create a free fatty acid that can be used for energy or used to create an individual phospholipid that's necessary for a particular area of the membrane. Now, the last kind of taxonomy we have to discuss is steroids and sterols. And a steroid is basically going to be any hydrocarbon with this 4-ring structure. It's got 3 6-member rings and a 5-member ring, and then it's going to have a little hydrocarbon tail off on one end of it. And a sterol, as opposed to a steroid is going to be a steroid with an alcohol group stuck on it somewhere. It could have 2 or 3. And a stanol is going to be a saturated sterol, and that's a sterol that we can't do anything with. And phytosterols, which are plant sterols, are stanols. So we don't really have the enzymatic machinery inherent within our DNA to be able to metabolize those and break them down and do anything with them. So they'll accumulate as trash within cells, and for that reason, we pump plant sterols or stanols outside of the body whenever we see them in the gut. Now, all of these lipids exist in all of your cells for the sole purpose of maintaining membranes. That's first and foremost, because you couldn't have a cell without a membrane, right? You've got to have something that separates you from the environment, and the bilayer membrane is exactly that. And a secondary function of lipids is to provide energy, because as it turns out, lipids are very energy efficient. You can get 9 kilocalories per gram of fats versus only 4 from sugars or proteins. So fats are more than twice as efficient, metabolically speaking, as these other energy sources that we can metabolize. So your body preferentially stores fat because of this, because in a pinch, it wants to be able to pull out a highly efficient energy from its stores. And on top of that, fats are a little bit more densely packing than glucose. Thinking about glycogen, which is the storage form of glucose, because glucose is polar, it interacts with water. And so one molecule of glycogen can have a lot of individual H2O molecules interacting and occupying space in between the sugars in that molecule of glycogen. Free fatty acids are stored as triglycerides, and because they are hydrophobic, water does not get in between free fatty acids and triglycerides, so they are very dense packing. So all of these factors explain why your body has so much fat in its stores. It needs to make membranes constantly. It needs to make hormones constantly. Fats are constituents of hormones, and it needs to have a store of energy to be able to use should you go into the fasting state and require more energy. So With these roles in mind, you can start to understand why the body is always packaging and transporting fats in the bloodstream. And it's a little bit of a misconception or a misnomer to always be referring to these lipoproteins in the blood as cholesterol, your HDL cholesterol, your LDL cholesterol. And I want you to know right off the bat that cholesterol transport is probably the dead last reason why we have all of these lipoproteins floating around in your blood. As we just mentioned, you need lipids for energy, you need lipids to build membranes, and you need lipids to build signaling hormones. And all three of these purposes are definitely more important than simple cholesterol transport, So it's a lipid homeostasis being maintained by the movement of lipid particles throughout the blood, and cholesterol is simply a oversimplified way of viewing it. And the reason it's not a cholesterol transport system is because every cell in your body is capable of making all the cholesterol it could ever need. You can synthesize cholesterol de novo, and the enzyme that does that is called HMG-CoA reductase. And HMG-CoA reductase gets turned off whenever your cells are receiving cholesterol from the outside. So if there is no cholesterol being obtained from the diet, your cells are still quite capable of making all the cholesterol that they ever need. Even if they're a liver cell, even if they're a cell on the tip of your ear, you can make cholesterol. So pathologies arise because we get too much cholesterol, We don't really need cholesterol per se. We need the lipids that are transported in lipoproteins. And whenever there is too much cholesterol in the diet, the cholesterol just accumulates within cells and it starts to form vacuoles and it starts to form extracellular aggregations. And a really important thing to know is that cholesterol crystallizes whenever it clumps together. If there's too much cholesterol, it'll start to layer in an ordered entropic format, meaning there's a pattern to it, which means that there's a shape to it. It's not just some vague ball of cholesterol. It's going to stack in a predictable pattern, so it's got angles to it. And because it has angles, if that cholesterol crystal gets too big, it can poke a hole in a membrane. That's really bad. That's where pathologies come into the picture, because cholesterol crystals accumulate, and then the macrophages that go to eat up all that free cholesterol in your extracellular interstitium, they pop open because the cholesterol crystallizes within them, and they're not built to be able to withstand that sharp needle straight to their membrane. So we get all this extra cholesterol built up in our cells and in our interstitial space because it's in our diet, because we absorb fats from our diet. And with the modern American diet, there's cholesterol in potato chips. There's cholesterol in some breads. There's cholesterol in foods you would never expect there to be cholesterol in. So over the span of many decades, this will build up. And as we'll get to in a later SDL, the chief presentation of this is atherosclerosis and ischemic heart disease downstream from that. But in cases of familial hypercholesterolemia, excess cholesterol packets can present acutely on the skin as these things called xanthomas, which we'll get to shortly. So that's what lipids are. Let's start to think about lipoproteins, because lipoproteins are packages of lipids that float through the blood. They're spherical, and they have a protein and a lipid component to them. Now, the protein component is called the apoprotein. And when I say the apoprotein, I'm referring to what gets printed out of a ribosome as an mRNA is translated and a protein product is synthesized. That's going to be your apoprotein, only the protein. Now, when that apoprotein goes to the Golgi apparatus or the endoplasmic reticulum and fuses with a vesicle containing lots of lipids, those lipids are going to aggregate on the structure of that protein chain, and then it becomes a lipoprotein. So a lipoprotein has lipids on it, and it's that spherical package, and an apoprotein is only the protein. So with that in mind, the apoprotein is important because it gives lipoproteins a signature. We are able to tell different lipoproteins apart because they have different apoproteins on them. And the different apoproteins are different sizes, and they have different charges on them, which means that if you drop them in a gel and you run a current through it, and that's called electrophoresis, then these proteins are going to move different distances down that ionically charged gel. So that's the basis by which we can differentiate different apoproteins, is by their size and movement in a charge. Now, the apoprotein also determines which receptors a lipoprotein can bind to. And there's an LDL receptor and an HDL receptor. And only the apoprotein A is going to bind the HDL receptor. And all the other apoproteins are going to bind the LDL receptor. And this is important because the LDL receptor binds different apoproteins with different affinities. For example, APO48, which is found on chylomicrons, has a little bit of a higher binding affinity for the LDL receptor than ApoB100, which is found on your LDL, which is a large contributing factor to why LDL is your bad cholesterol, because out of all the apoproteins, ApoC, ApoB48, ApoB100, ApoA, ApoB100 has the lowest binding affinity for the LDL receptor, which means that it gets cleared at the slowest rate of all apoproteins by the liver. So lipids don't enter the bloodstream unless they're bound to an apoprotein in the form of a lipoprotein. And this is obvious because, as we started off with, lipids don't like water. They don't play nice with water. If you put it in water, it's going to get all out of order, and it's going to fold up into itself to achieve the lowest free energy state possible. And because it doesn't interact with water, that lowest free energy state means that it's got to interact with itself rather than the environment. So we package lipids into lipoproteins, and we give it a hydrophilic shell or sphere on the outside of it so that the hydrophobic lipids can travel safely, nice and cozy within, and not even be aware of the fact that they're moving through this blood. So lipoproteins are then made in your liver and in your gut by the enterocytes that line your gastrointestinal tract, because these two organs are the point of contact organs between your body and the environment when it comes to lipids. Let me rephrase that. You get lipids in from the environment because you eat them. You get dietary lipids. Where do they go? They go down the GI tract and eventually they get absorbed. And so you need to be able to make lipoproteins in the organ that absorbs lipids, because how else will it get them into the bloodstream? Because lipids don't play nice in the blood. So you make lipoproteins within the GI tract, and you also make them in the liver because the liver is the principal metabolic organ. Specifically, your enterocytes in the gut make chylomicrons, and chylomicrons are directly associated with the absorption of lipids from the gut. The liver doesn't make chylomicrons. The liver instead makes this thing called VLDL, or very low density lipoprotein. And the liver also makes low density lipoprotein. And the liver also makes high density lipoprotein, which has an ApoA on it. And the different apolipoprotein components of each class of lipoprotein, the different apoproteins on them, determine which receptors they can bind to. So all of these lipoproteins take lipids, including cholesterol, from the gut or the liver to the peripheral tissues of the body. They're delivery mechanisms for lipids and for triacylglycerides and for phospholipids. And cholesterol is, I suppose, part of what gets delivered to these cells. But remember, the main reason why you have lipid transports is to give cells lipids to store as energy, adipocytes, and to use for the construction of membranes. And HDL does the opposite. It takes free lipids that get deposited outside cells, and it takes free lipids from inside cells, and it returns them to the liver. And your liver can take lipids and excrete them as bile, and then they'll go out your GI tract, and you'll never hear from them again, you know. So you can excrete lipids once and for all, permanently. And HDL is the mechanism by which lipids get from the rest of your body to the liver so that they can be excreted in bile. So taking this into consideration, your chylomicrons, your LDL, your VLDL, all of these could be said to be a forward cholesterol vehicle, a forward transport mechanism, because they're taking cholesterol from the outside of your body throughout the rest of your body. And then HDL could be said to be your reverse cholesterol transport mechanism, because it's taking excess cholesterol that has accumulated throughout all of your tissues. It's taking that cholesterol back to the liver so that it can be repackaged and sent out to the body as a LDL, or it can be excreted in bile. So that's a very brief overview of lipid transport and metabolism. What I'm going to do now is move on over to the hyperlipidemia SDL and start to discuss some of the familial hyperlipidemia syndromes that we see within. So this SDL is structured so that everything has a genetic component and everything has associated lab values. We've had a few SDLs like this before. One that comes to mind is the glycogen storage diseases. Another that comes to mind is the lysosomal storage diseases. So, you know, you ought to have a decent frame of reference for how to begin interpreting or approaching this specific text. Right off the bat, we get into the Fredrickson classification of hyperlipoproteinemias, and there are 5 categories. One has a subcategory within the Fredrickson classification. What's important to know is that type 1s and 5s are similar. They'll present with lowered LDL cholesterol, and they are associated with eruptive xanthomas. Type 2A Fredrickson is the most common type of hyperlipoproteinemia. It's associated with normal triglycerides and some very characteristic broad spectrum symptoms. A type 2B is essentially a type 2A, except it's got VLDL elevated as well as LDL. A type 3 Fredrickson has high chylomicrons, and it's the only one that has high chylomicrons. And then finally, a type 4 has only an elevated VLDL, nothing else is elevated. This text starts off with the type 2 Fredricksons, which are going to be the increased LDL cholesterol disorders. Before we get into familial hypercholesterolemia, there is a separate table on page 4. And this is kind of the diagnostic chart. And it's going to tell the clinical phenotypes of the different Fredrickson classifications. And I wanted to quickly mention that all of the type 2As have this very broad presentation of premature atherosclerosis. So we're talking about like 30-year-olds, 40-year-olds with these atherosclerotic events such as stroke or ischemic heart disease at an early age. They present with xanthomas, which we will get to at the end of this SDL. A xanthoma is basically cholesterol acne or a cholesterol tumor, and it's nothing but cholesterol and foam cells on the inside of it. And then finally, they'll present with a corneal arcus, which is the deposition of cholesterol along the rim of the cornea. And remember that cholesterol forms crystals whenever it aggregates, and that the cornea is a very thin layer of tissue. It's got a Bowman's membrane on the outside and a Decimet's membrane on the inside. And it's very, very easy for a sharp shape to puncture that thin layer of Bowman's membrane from the outside or Decimet's from the inside. And get through the vascularized uvea and start to protrude into the cornea. That's why you're going to have the ring around the cornea, around the periphery, is because that's where the bloodstream meets this avascular cornea. And where the bloodstream is, that's where cholesterol gets deposited. So that's where cholesterol crystallizes. So that's where it pokes a hole within the cornea and starts to creep within the middle layer. Then we get into the type 3, 4, 5 Fredricksons. We get into these other disorders, and they're kind of grouped in pairs, and they have very particular symptoms. So if you are a table type of person, then I would start in the middle of this table and work outwards towards either side. So getting into familial hypercholesterolemia. It's an autosomal dominant disorder, a type 2A Fredrickson classification, and it's a problem with the LDL receptor gene. And I like to make a note of these broad classifications right at the top of any pathology that I come across in an SDL, because it allows me to revisit the text and scan through it quickly, so that whenever I flip to a disease, I've got autosomal dominant type 2A right there, so that it's the first thing that comes to mind when I think of the name of the disease. So that's the best way to remember the small minutia of each disease, or the things such as inheritance patterns that can be easily confused. You know, put it right there next to the name, so that every time you open the text, you have to look at its inheritance pattern. You're going to remember it then. A familial hypercholesterolemia is exactly what it sounds like. There's too much cholesterol in the blood, and it's caused by a mutation in the LDL receptor. Now, you have the LDL receptor on almost every cell of your body, barring red blood cells. This schematic here is an excellent representation of what the LDL receptor does. It will bind to a lipoprotein and endocytose that lipoprotein. And what's inside of a lipoprotein? Fats. So that's why every cell has the LDL receptor, because every cell needs the capacity to use fats as energy. And I want to take a brief moment to say that not every cell in your body has a lot of glycogen. We think about glycogen stores, and we think about our skeletal muscle, right? And we think about our liver, and it seems very obvious that these obvious organs that we think of on a frequent basis have a lot of glycogen in them, you know? But the endothelial cells lining all of the blood vessels of your body, and the functional parenchyma cells of, say, the kidneys and the thyroid gland and your brain, they don't have large glycogen stores, you know? And they certainly don't have enough glycogen to be able to power your body on a continual basis without needing replenishing. So because these cells don't have large glycogen stores, they always need energy. And because they always need a constant refueling, it's like having to get gas. Like, imagine if you had a car that had 1 gallon of gas on it, you know, you'd be getting gas every day. That's what most of the cells in your body are like. They don't have the same glycogen stores that your liver and your skeletal muscle does. So that's why you need to get this LDL to all of these cells in your body to begin with, is because they need energy, because they have small gas tanks and they always need that gas refilled. So the process of getting that gas into the cars of these cells is the endocytosis of LDL. And whenever there's a problem with that, you can't get LDL into these cells. And they can mainly function. You know, you're not going to die just right off the bat because you can't get LDL in, because you'll still get some in a moderate amount. But what you'll see is that LDL will start to accumulate outside the cell, because the liver has a lot of LDL receptors on it. And it's the liver, because it's the LDL receptor, that normally removes LDL from the circulation. And remember that once the liver removes LDL from circulation, it can excrete it as bile. And if this capacity of the liver is impaired, then you're going to have a very hard time clearing fats, total fats, from your body. So familial hypercholesterolemia is an inherited disease. It affects 1 in 500 people roughly, and it's got a strong genetic component. You can be homozygous or heterozygous for this LDL receptor mutation. And it's not just one mutation. There are quite many different point mutations that can result in marginal or large decreases in function in the LDL receptor. And then some people too have kind of gain of function mutations, relatively speaking. My point is that there is no normal when it comes to genetics. It's always a continuum of some people have a better receptor activity, some people have diminished receptor activity. This is what we're referring to with the LDL receptor inherited deficit. Some people have a little bit worse, some people have a lot worse. You can be homozygous, you can be heterozygous. The LDL receptor, as we said, is present on every single cell in the body except for red blood cells. If you have a diminished LDL receptor function, then you're going to have high blood LDL cholesterol. And furthermore, because all of the cells of your body can synthesize cholesterol de novo through that HMG-CoA reductase, which is turned off by exogenous cholesterol, well then a lack of cholesterol being delivered to any cell is going to result in an increase in de novo cholesterol synthesis. So this happens in familial hypercholesterolemia, and one of the bad complications of that is going to be non-alcoholic fatty liver disease. At the microscopic level, at the histopathologic level, you start to see foam cell formation because you have the deposition of cholesterol into various tissues, and that cholesterol is hydrophobic, so it clumps and sticks to itself. And because cholesterol has a predictable planar structure, it will form sharp angles as it stacks and crystallize, and those cholesterol crystals, as they get larger and larger at the macro level, will begin to puncture membranes. And so you see foam cells, which are macrophages with cholesterol inside of them. You'll see foam cells because that's the only way that you can remove cholesterol from the spaces, the extracellular spaces in between cells. Getting back into the genetic component of it, homozygous familial hypocholesterolemia is going to be worse in presentation than heterozygous. Why? Because they have two deficient copies of the LDL receptor rather than just one. If you are homozygous for an LDL receptor mutation, then you're going to have very high total cholesterol levels. We're talking about greater than 600 mg per deciliter, and you're going to have normal triglycerides. The main presenting symptom of familial hypercholesterolemia is premature atherosclerosis, which can manifest as, namely, ischemic heart disease, but also as renal stenosis or maybe even an aortic dissection. Heterozygous familial hypercholesterolemia is not as bad. You still see an elevated LDL, but it's not as elevated as in a homozygous familial hypercholesterolemia. And you'll also see normal triglycerides. And once more, you will see the same side effects of ischemic heart disease, premature atherosclerosis, and xanthomas. And xanthomas are aggregates of cholesterol within peripheral tissue, specifically the skin. So you've got this kind of broad constellation of early atherosclerosis, ischemic heart disease, and xanthomas, and that's going to apply to all of the type 2A Fredrickson classification diseases, which present with elevated LDL but normal triglycerides. So that's familial hypercholesterolemia. It's the most common one out of the type 2A Fredricksons, and type 2A Fredricksons are the most common out of the familial hyperlipidemias. Moving on to familial defective apolipoprotein B100, it's autosomal dominant and it's a defect in the ApoB gene. And apoprotein B is found on LDL particles. It's also found on VLDL particles and chylomicrons, but chylomicrons have ApoB48, which is smaller than ApoB100. The 48 and the 100 refer roughly to the size of the protein product. So a familial defective apolipoprotein B100 is only going to affect LDL and VLDL and IDLs, which is in between VLDL and IDL in that size density spectrum. So if you have this specific type of ApoB mutation, what it means is that your ApoB protein, which binds to the LDL receptor to mediate lipoprotein endocytosis, doesn't want to bind as tightly to the LDL receptor. As a consequence, the affinity of the mutant ApoB100 is 3 to 5% of normal, and that's the big takeaway. Symptomologically, it's going to look exactly the same as familial hypercholesterolemia. You're going to see xanthomas, premature atherosclerosis, and ischemic heart disease. Autosomal recessive hypercholesterolemia is going to present with the same symptoms: atherosclerosis, xanthomas, ischemic heart disease. This is a problem in the LDL receptor adapter protein. It's got a predilection for Italians, and the LDL receptor adapter protein is going to be active at this particular stage of endocytosis whenever the LDL receptor has already bound to an apoprotein and it is in the process of being endocytosed. That clathrin-mediated endocytosis is what goes wrong when there's an LDL receptor protein, LDL-RAP mutation. Going back to where I was, sorry that the flow got a little bit disturbed there. Now we are looking at autosomal dominant hypercholesterolemia. And autosomal dominant hypercholesterolemia is a PCSK9 gain of function mutation. It's inherited in an autosomal dominant manner. PCSK9 is a protein that degrades the LDL receptor. And whenever PCSK9 grabs onto an LDL receptor, it basically destroys that receptor. So less LDL receptor means that there's less LDL being taken up from the blood by the liver, which is going to lead to higher blood LDL over time. PCSK9 is a target, a quite recently discovered target of lipid-lowering therapy. PCSK9 inhibitors are something that we're going to learn about in pharmacology. I won't say anything about it other than that, other than to be aware of PCSK9 and what it does. Finally, Sitosterolemia is going to be a defect in the ABCG efflux pump. You've got these ATP binding cassette transporters, and their job is to move cholesterol from the inside of cells to the outside of cells. And they're very prevalent within the gut, within enterocytes lining the gut, because that's the point of contact between your body and the environment when we're referring to lipids. Enterocytes get to decide, are we going to keep this lipid or are we going to put it back into the lumen? And as it turns out, you want to put lots of lipids back into the lumen. Why? Because there are some lipids, specifically plant lipids, that your body wants nothing to do with. It can't metabolize them. It can't use them as hormones. It can't put them into the membrane. So they're toxic if they accumulate. And the way that we know that they're toxic is because the ABCG protein, which is an efflux pump for cholesterol, binds to cytosterols, plant sterols, with a much higher affinity than it does to your own cholesterol. So somewhere along the way, our genetic blueprint, got coded to pop plant sterols out of the body. And when there's a problem with this, i.e. when you see a lot of plant sterols in the blood, they can become toxic very rapidly. Going through the text, again, this paragraph tells us that the efflux pump for cholesterol is found in the intestine because it wants to put it back into the lumen, and in the liver because it wants to be able to efflux cholesterol as bile. And the efflux pump promotes biliary excretion of sterols. It is going to pump out all sterols. So if there's a defect in the ABCG gene, you see a decreased biliary elimination of all sterols, specifically plant sterols. That's not good. That becomes toxic. A final important note that I didn't highlight is that this typically presents in childhood, the first 10 years of life. Because plant sterols are so bad for you, you're going to know very soon if you have this defect. And finally, the last type 2A Fredrickson that we're dealing with is the polygenic hypercholesterolemia. Polygenic hypercholesterolemia is a fancy way of saying we don't really know what's going on. It's idiopathic, and it could be due to a great multitude of different genes interacting with one another. So because it's so multifactorial, we just call it polygenic. It presents very similarly, albeit without tendon xanthomas, to the other type 2As. It's due to SNPs, single nucleotide polymorphisms. And right here, something I highlighted that I found noteworthy was that a low-fat diet should be the very first treatment option for any patient with a hyperlipidemia. You need to try to get them to modify their diet and start getting more exercise first thing. And lipid-lowering therapies are very effective, but on a test question, that's usually not going to be the first line treatment option, because get their diet better is just, it's free, you know, it has no adverse effects. It's always the safest option. So on a test question, what's the best therapy? Well, have you tried eating healthier? That's always what I'm thinking. So now we move on to two disorders characterized by a decreased blood LDL. And the difference between these two disorders is that one of them is fatal by like 30 or 40. That's Abetalipoproteinemia. And the other one you can live for quite some time with and have a normal, happy, healthy life. Abetalipoproteinemia is an autosomal recessive inherited defect in the microsomal triglyceride transport protein. And MTTP is necessary for the efflux of cholesterol into the bloodstream. So you have to be able to pump triglycerides, you know. You got to be able to mobilize fats from inside your cells into LDL and into chylomicrons, because fats don't travel on their own in the bloodstream. So you have to put them into a lipoprotein. So MTTP is the transfer protein that takes fatty acids and puts them into the lipoprotein. And if you can't do this, then you really can't make lipoproteins, you know. So it's namely going to affect enterocytes, because the gut is the primary site of fat absorption. It presents as fat malabsorption. That's its characteristic symptom. So you get a vitamin E deficiency. You also get an ADK deficiency. So think about what you're going to see in fat-soluble vitamin deficiencies. You can get a fatty liver, and you can get acanthocytes too. And you'll see these problems with your red blood cells because, well, you're always making red blood cells, and that means you're always making membranes. And red blood cells have very particular membrane requirements. They need to be extremely fluid because they're always moving throughout the blood, you know, and they always have to change shape and adapt to whatever stresses are being put onto them from different angles. And if you can't create properly fluid membranes, then you're going to have these strangely shaped red blood cells. And even in anemia, if the lipid deficit becomes too much. In blood work, you're going to see triglyceride deficiencies, really low triglycerides, and undetectable LDL levels. And remember, this is Abetalipoproteinemia. And the reason for that is because, again, you're not able to create lipoproteins and send them out into your blood from your gut. So familial hypobetalipoproteinemia is very similar in symptom presentation to abetalipoproteinemia, but it's less severe. It's an autosomal codominant mutation in the ApoB gene. And remember that ApoB48 is found on chylomicrons, and you need an ApoB48 on the chylomicron to put it in the blood and allow it to bind to cells and give lipids off to those cells. And you need an ApoB48 to get the chylomicron to bind to the liver so that you can get it out of the bloodstream. And then you need ApoB100 so that you can synthesize LDL and VLDL particles in the liver so that you can transport fats to the rest of your body. And if you have a defective ApoB gene, so a defective apolipoprotein B, then it can't hold as many fats, speaking on a quantitative basis, as a healthy apolipoprotein B. This results in diminished capacity to transport lipids throughout the blood. So you're going to see a very, very low total cholesterol because the vehicles responsible for transporting that cholesterol are lipoproteins. And those lipoproteins are very dysfunctional if they have an ApoB that's shaped weirdly or is smaller than usual. What I have selected out of this is that plasma LDL is going to be pretty low. 25 to 45 is a narrow range and is quite particular to this disease. It'll show normal triglycerides and patients have a normal lifespan. So there are two disorders that have low LDL. One's Abetalipoproteinemia, that's a total lack of the LDL lipoproteins due to the NTTP mutation. And then the other one is going to present later in life with less severe symptoms. Refer to the chart on page 4 for the symptoms. They're not really talked about much in these paragraphs. So now let's talk about familial dysbetalipoproteinemia. This is a type 3 Fredrickson, and it's characterized by increased VLDL and increased triglycerides. And this is the first disease in this SDL that presents with an increased triglyceride count. Familial dysbetalipoproteinemia is a defect in the apolipoprotein E gene. And ApoE, if you remember Alzheimer's and neuroblock, ApoE has a few variants. Most people have ApoE3. People who have ApoE2 have a decreased affinity for the ApoE receptor. And people who have ApoE4 have lipoproteins with an increased affinity for the ApoE receptor. Now, ApoE will bind to its receptor, and then when that happens, whatever cell has that receptor on its surface is going to scoop up that apolipoprotein. It's going to scoop up that lipoprotein and suck it into the cell so that it can access all of the lipids within. So if you have a decreased affinity for the ApoE receptor, that means that it is more likely that that lipoprotein is in the blood rather than in a cell. And then vice versa, in the case of an ApoE4, well, if you express the ApoE4 variant of apolipoprotein E, then those are getting snapped up by every cell so quickly because of that increased binding affinity for the ligand by the receptor. So people with ApoE2 as a result are going to have high lipoproteins, and people with ApoE4 are going to be protected against high lipoproteins. Specifically, familial dysbetalipoproteinemia develops because of a decreased clearance of chylomicron and VLDL. And The ApoE dysfunction explains this because you do not have ApoE on low-density lipoproteins. You only have ApoB100 on low-density lipoproteins. That's the only protein on an LDL particle is the ApoB100. ApoE is unique to chylomicrons created by the gut and VLDL created by the liver. So if you have this familial dysbetalipoproteinemia that leads to an increased blood chylomicron and triglyceride content, you're going to see plasma cholesterol levels in the 300 to 600 mg per deciliter range and plasma triglyceride levels in the 400 to 800 mg per deciliter range. Symptoms are, again, broad and characteristic of just about any syndrome with high cholesterol. You see xanthomas, you see accelerated atherosclerosis, premature ischemic heart disease. Another thing I picked out of this paragraph was that hepatic lipase deficiency mimics familial dysbetalipoproteinemia. And what a lipase does, anytime you see lipase, you know that that's going to be cutting a fat molecule. And fats are stored as esters. And so to remove a fat from its storage unit, you have to deesterify it. And a lipase is the sort of enzyme that you need in order to cut and separate a free fatty acid off of an ester bond. So if you have an inability to cut fats off of their storage form, it's going to be very similar to an inability to get those fats into the cell to start with. That's why the lipase deficiency presents similarly to familial dysbetalipoproteinemia. Then we have a familial combined hyperlipoproteinemia, which is going to be an overproduction of hepatically derived ApoB100. Remember, ApoB100 is on VLDL, IDL, and LDL. ApoB100 is not on HDL and it's not on chylomicrons. So only your VLDLs are going to be affected and your LDLs too. Basically, the familial combined hyperlipoproteinemia is a type 2A Fredrickson. So with the accelerated atherosclerosis, premature ischemic heart disease, but without the xanthomas. So you won't see the xanthomas, you will see high triglycerides and you will see high LDL. Moving on to disorders characterized by increased triglycerides, we're looking at familial chylomicronemia syndrome, which is an autosomal recessive inherited disorder. This is a type 1 Fredrickson classification, and it's a defect in either the lipoprotein lipase or the ApoC gene. So we just talked about how a lipase is responsible for deesterifying a fatty acid. And that means it's responsible for creating a free fatty acid from an esterified fatty acid. And you need to be able to free fatty acids if you want to do anything with them. So a lipoprotein lipase defect means that you are capable of delivering lipids throughout the blood packaged in lipoproteins, but you are incapable of doing anything with the products of those lipids once you put them onto a cell. You need lipoprotein lipase to deesterify lipids to move them into the cell. So if you have an LPL defect, you have the lipoproteins, you have them in normal quantities, you just can't do anything with them. ApoC is the protein on the lipoprotein that binds to lipoprotein lipase on the cell surface. And when the ApoC2 on a lipoprotein binds to lipoprotein lipase, that lipase starts cutting up all the fats inside and sucking them up like how you drink an icy through a straw. That's what lipoprotein lipase does. ApoC2 is not an inherent protein on the surface of anything but HDL. And what I mean by that's kind of a complicated way to say it. HDL is made with ApoC2. All the other lipoproteins in your blood have to get ApoC2 from HDL. And this happens by means of simple collision. You know, you got an HDL flying around in your blood, and then you got a VLDL in your blood, and they bump into each other. And when they collide, sometimes that ApoC2 just says, oh, hey, I'm going to go over here instead, you know, and that's what it does. It'll do that on a chylomicron. It'll transfer itself over. It'll just get rubbed off onto a chylomicron or a VLDL, but it originated on an HDL. So that's important to know because it's part of why HDL is good cholesterol. ApoC2, what ApoC2 does is it's just another binding site for cell surface receptors. So ApoC2 says, hey, pick me up, I'm in the blood. And the receptors on the surface of cells say, oh, hey, I can bind ApoC2. I'm going to bind ApoC2. So it just grabs that lipoprotein and puts it into the cell. And that's a good thing because you want low blood fats and you want lipids being delivered to your cells so that they can use them, so that they can upkeep their membranes, and so that they can have enough energy to perform their metabolic processes. And yeah, that's the gist of ApoC2. It's just one more means by which a lipoprotein is endocytosed. So when there's a defect in this process, that means there's less lipoproteins being scooped up by your cells, and then there's more lipoproteins in the blood because they can't be scooped up as efficiently. That's what's going on with this chylomicronemia syndrome, and specifically it's high chylomicrons because ApoC2 gets given to chylomicrons by HDL, and it's a large part of why chylomicrons can be absorbed by so many different tissues, because not only does it have ApoB48 on it, it also has ApoC2 on it. So the symptoms or the clinical presentation of a familial hyperchylomicronemia are going to be fasting triglyceride levels through the roof with normal plasma cholesterol levels. And that's because this disease only affects chylomicrons. And chylomicrons are produced by your gut. And cholesterol particles, you know, are produced by your liver. And so this is not something that really affects LDL or VLDL as much as it affects chylomicrons. I feel like I misspoke there a little bit, so kind of disregard my explanation for that high triglyceride level. Just know that triglyceride levels are through the roof in this syndrome. Heterozygous individuals with only one bad copy of LDL or one mutated copy of ApoC2 are going to have relatively normal blood work. The symptoms are going to present as eruptive xanthomas, and this is the first time that we have seen eruptive xanthomas within this text. Eruptive xanthomas present as rashes, and they are multiple. They will kind of look like acne, you know, whereas an individual xanthoma could be kind of a tuber, like a golf ball, you know, or a jelly bean under the skin. Eruptive xanthomas are going to be lots of dots all in the same cluster. This disease may also present with a hepatosplenomegaly as a result of foam-filled macrophages having to clear all of those triglycerides from the blood. And as a result of all the triglycerides in the blood, your liver and your spleen are kind of your Brita filters for all of your blood. And so whenever your blood looks like this on the left, you know, they got some work to do. So that's why you see that symptom. And that blood that is so milky in coloration is referred to as lipemia retinalis, and it's fairly distinctive to the type 1 and the type 5 Fredricksons. You're only going to see blood work like this in the types 1 and 5. Last things last is that if you perform a fundoscopic exam and you look at their blood vessels, they could be like literally opaque. And that's what's going to clue you into, oh, this person has high blood triglycerides, because high blood cholesterol will not do that to the appearance of your blood, but high triglycerides will. And then we have familial hypertriglyceridemia, which is essentially many of the same symptoms, eruptive xanthomas and milky blood. However, it will present in children. It's got an earlier presentation. It's a little bit more severe. And it's also going to be a lipoprotein lipase defect. Moving into decreased HDL disorders. So what we've been talking about up to this point is your forward cholesterol transport involving LDL, VLDL, and chylomicrons, and their ability to deliver lipids and cholesterol from your gut and from your liver to the rest of your body. Now, if there's a problem in delivering lipids from your gut and liver to the rest of your body, then you can see high blood triglycerides. But you also have a reverse cholesterol transport mechanism, and that's mediated by HDL. And what happens when HDL takes cholesterol from your tissues to your blood is that HDL binds to macrophages, because macrophages are the cells responsible for scooping up free cholesterol and giving it to HDL so that HDL can move that cholesterol back to the liver. And in order to do this, there's a cholesterol efflux pump on the surface of a macrophage that is going to bind to a cholesterol influx pump on the surface of an HDL lipoprotein. And this communication allows for macrophages to squeeze lipids into HDL. And HDL will float around the bloodstream, and it'll just pick up lipids from macrophages and from other cells that it bounces off of as it travels throughout the lumen of the blood. And it'll pick up lipids from these cells, and then finally it'll get to the liver. And the liver has an HDL receptor which will scoop up the HDL and draw it into the tissue. Now, when this happens, that excess fat, lipids, can be squeezed out by the liver in the form of bile, and it can be excreted into the gut and permanently disposed of. So that's the mechanism of your reverse cholesterol transport mediated by high-density lipoprotein. And obviously, taking all that into consideration, anything that decreases the quantity or quality of your HDL lipoproteins is going to simultaneously decrease your ability to move fats out of the body. And so they accumulate. And so then they present with symptoms. This is what happens in familial hypoalphalipoproteinemia, which is an autosomal dominant mutation in the ApoA1 gene. ApoA1 is an apoprotein, just like ApoB48, just like ApoB100. So that means that this protein is able to bind to receptors that will scoop up a lipoprotein and endocytose it. The difference is that ApoA1 is on HDL and no other forms of cholesterol. If someone has familial hypoalphalipoproteinemia, they have very low plasma HDL in the 15 to 30 mg per deciliter range, and that's going to be the most diagnostic clue that you get in a question stem. You can see corneal opacities and xanthomas. You can see accelerated atherosclerosis and ischemic heart disease, and know that all of these symptoms are downstream of having high systemic lipids. The second low HDL disease is the LCAT deficiency. Lecithin cholesterol acyltransferase is an esterification enzyme, right? So whenever you take a free fatty acid, such as the type of fatty acid you would absorb from the gut, and move it around, you have to esterify it, to store it, to get it to fit inside of a lipoprotein in a nice, tightly packed way. So when you esterify a fatty acid, you put it into storage. And when you de-esterify a fatty acid, you move it out of storage and you put it into the cell, and you let the cell use that fatty acid. And lecithin cholesterol acyltransferase is a specific enzyme found in HDL particles that catalyzes the esterification of cholesterol. And as a side note, briefly, there is another cholesterol acyltransferase called the acylcholesterol acyltransferase, and that's found within the enterocytes of your gut. So anytime you see LCAT or ACAT, you know that this is an enzyme that is going to catalyze the esterification of cholesterol and thus the storage of cholesterol or of a lipid onto a ester. So there are two forms of LCAT deficiency. There's familial LCAT deficiency, which is an abolishment of both alpha and beta LCAT activity. And then there's fisheye disease, which is going to be less severe because it's only the abolition of an alpha LCAT activity. So familial LCAT's worse, fisheye is a little bit better. And if you can't esterify cholesterol, you know that you cannot store cholesterol, and thus you cannot put cholesterol into your HDL particles to transport that cholesterol and those lipids back to the liver to allow the liver to dispose of them permanently by secreting that product in bile. So if you lose LCAT function, then you can't put cholesterol into HDL. That's it in a nutshell. Again, the familial deficiency is a total loss of LCAT function. It's going to present as corneal opacification with a mild hemolytic anemia and a proteinuria. The reason you get a corneal opacification is because the membranes of the cornea are very thin and they are easily penetrable by cholesterol crystals, which are sharp. The reason you get a hemolytic anemia is because if you don't have enough cholesterol in your body, being transported in your blood, then you're not able to produce membranes in mass amounts, and red blood cells need membranes to be able to survive. Fisheye disease is a less severe variant with only the alpha LCAT loss of function. It's got a really low cholesterol, less than 10 mg per deciliter. And for this section of, decreased LDL or decreased HDL cholesterol pathologies, I'm really differentiating them by the range of their HDL on blood work because they are pretty distinctive between all three of these pathologies. So then finally you have Tangier disease, and Tangier disease is a dysfunctional mutation of the ABC1 transporter. Now, remember that whenever macrophages scoop up free cholesterol, they have to do something with it. They can't just chew up this cholesterol. They don't have the enzymes to do it most of the time. So it accumulates in vacuoles, and the way that they get rid of it is by giving it to HDL. And in order to give it to HDL, the macrophage has to pump it out of ABC1, and the HDL has to pull it in using LCAT. So both those enzymes are involved in the disposal of free cholesterol through macrophages to HDL, to the liver, and out your body. Tangier disease has pathognomonic orange palatine tonsils. It has the lowest plasma HDL of all three of these diseases in this subsection, less than 5 mg per deciliter. You see cholesterol accumulation in the reticuloendothelial system. You see lipid-laden foam cells on histology and hepatosplenomegaly. Moving on to a few secondary causes of hyperlipidemia briefly. These are such broad topics that I'm sure you could go online and find dissertations on metabolic syndrome and hyperlipidemia, or hypothyroidism and hyperlipidemia. So what you need to be able to take out of this section is, I would say, the presentation of metabolic syndrome. It's discretely obesity plus hypertension plus diabetes plus elevated plasma triglycerides plus low HDL or high LDL, a cholesterol imbalance. That's what metabolic syndrome is. Type 2 diabetes is also considered a type 5 Fredrickson classification. I don't know what any test question is here in this text. There's just not enough to go off of. But at the morphologic level, when there's lots of fats floating around in your blood, they aggregate to one another because they're hydrophobic. Well, glucose exacerbates that process because glucose is what it sounds like. It's basically glue. You know, it's a ring with 6 alcohols on it, and it's really sticky. And when it's flying around in blood, it can stick to things and cause particles to stick together whenever glucose is the connector between them. So that's the function of glucose morphologically in a clot or in a fat atherosclerotic thrombus. Renal disorders, you're not going to get asked a question about a kidney disorder. We haven't even had that block yet. Liver disorders, we have looked at liver failure associated with high fats. That's your non-alcoholic fatty liver disease. We have looked at the liver metabolism of fats, so I suppose that anything biochemically in the liver pathway is fair game. Just kind of have a general understanding of what the liver wants to do with fats. So the liver wants to put out lipoproteins to give fats to the body, and then the liver wants to uptake those lipoproteins so that they don't float around in the blood too much, you know. And if they do float around in the blood too much, then they can become oxidized, specifically your LDL. It can creep into the tunica intima of your medium and large size arteries. So your liver is responsible for giving fat to your body and also bringing it back into the liver. And then your liver is responsible for breaking fats down and creating bile acids that get secreted into the gut so that you can permanently dispose of your cholesterol. Cholestatic liver disease is obviously anything that obstructs or impedes the flow of bile out of the liver is going to cause a backup kind of lipids within that section of your metabolic systems, and it's going to cause hyperlipidemia secondary to a cholestatic obstruction or maybe a dysfunctional gallbladder, dysfunctional liver. Xanthoma can be downstream from these GI diseases in which there is an obstruction of the bile duct. And finally, alcohol. In terms of where we are at in our studies right now, I think a fair question is something like, what's the pathophysiology, or what's the pathology, what's the biochemistry behind how alcohol impedes fatty acid oxidation? And the answer to that is that alcohol dehydrogenase creates NADH as a byproduct of its work, and then acetaldehyde dehydrogenase creates another NADH. And remember that fatty acid oxidation requires NADH as a signal to get it going and get it kicking. And so that high NADH discourages the beta oxidation of fatty acids and encourages the synthesis of storage triglycerides from free fatty acids. And that's what alcohol does to the liver. That's how you get non-alcohol, or that's how you get alcoholic fatty liver disease. You know, it's like, maybe I believe there's some alcohol involved there. So if you are a regular consumer of alcohol, otherwise known as an alcoholic, then you see elevated plasma VLDL and triglycerides due to increased lipolysis in adipose tissue, accumulation of free fatty acids in the liver, which promote hepatic triglyceride synthesis. Because remember, the alcohol is being metabolized by the liver. So the liver is not going to be making any fatty acids. Or I'm sorry, it's not going to be burning any fatty acids, but then your fat tissue is like, oh man, this dude is in an energy deficit. He needs some fats mobilized. And so they will go through lipolysis because the alcohol doesn't diffuse to them quite nearly as much as it does the liver. And they will be releasing free fatty acids. And you'll kind of be in this paradoxical metabolic state where you are in need of energy, but your liver doesn't think you are. So that's why the liver is doing one thing and your adipose tissue is doing another when it comes to fatty acid metabolism under the influence of ethanol. And finally, getting into xanthomas, the most characteristic clinical presentation of hyperlipidemias and hypercholesterolemias. There are 5 types. A xanthoma is basically a cholesterol plaque within the skin, and histologically you're going to see foam cells because they're the trash compactors. They're the waste management of all of your cells, and if they don't pick up this free cholesterol, who will? So lipid-laden foam cells. You have xanthelasmas, which are stones around your eyes. You have tuberous xanthomas, which occur at big joints. You have tendinous xanthomas, which occur at small joints, such as the extensor surfaces of your fingers and toes and your Achilles tendons. Side note, the tuberous xanthomas also occur preferentially at extensor surfaces of your elbows and knees, so large joints. You have eruptive xanthomas, which basically look like lipid acne. And then you have plain xanthomas, which are macular, meaning that they are flat. And macular is a fantastic doctor word to be able to throw out in any given conversation. You know, hey, what's this look like to you? Macular. You know, it makes you sound 10 times smarter. So that's what a plain xanthoma is. Now, these xanthomas are associated with various syndromes and hypercholesterolemias, but I believe that that particular part of these bullet points is there to inform you and to help coordinate your diagnoses. I think there's a very low chance that you get a question that says, here is a xanthoma. What disease is this associated with? You know, it's going to be like, here's the disease, they have a xanthoma, and the question will be more secondary or tertiary, you know, along the pathological lines than just simply match this with this. It's going to be like, what gene is out, or what's the intracellular ramifications of not having this gene? And then the xanthoma is just going to be a means of helping you say, for example, oh, it's an eruptive xanthoma. This is a type 1 or a type 5 Fredrickson, you know? So again, last things last, principles of treatment: change their diet. Try that first. You can excise these xanthomas if they're massive, which I suppose they are for a lot of people, because access to healthcare is not universally. And lots of people don't even think that they have a problem with the xanthoma because it's benign, and then they start seeing the symptoms of the atherosclerosis and the ischemic heart disease, and so then they go in to see the doctor and they say, oh, well, hey, while we're at it, we might want to excise this xanthoma. So that's what's going on with that. As I reflect back over this specific document, I think that there's for sure going to be a genetics test question. You know, there's going to be a what enzyme, like simply match the enzyme. There might be a pattern of inheritance question, just because it's listed for all of these, you know, so it might be useful to be able to spit out, hey, this one's autosomal recessive, this one's autosomal dominant. Within the type 2A Fredricksons, you know, all of them interact with this intracellular process here, the endocytosis of LDL and then the receptor recycling. So because these different diseases interfere with different stages or steps in this stepwise LDL endocytosis process, I believe it's highly likely for us to see a question about what specific stage in the LDL endocytosis process is going wrong given this patient. You know, so make the diagnosis, remember the gene, know what the gene does. I think that blood work is prevalent throughout all of these different pathologies, and the chart on table 2 is probably included, you know, for the specific purpose of helping us identify different classes of pathology based on blood work alone. So I think that knowing the trends is more helpful than knowing discrete ranges, because I think that the question would be something more like, you've got a type 2B Fredrickson's. What do you expect? And you have to be able to say, well, okay, it's going to be high triglycerides and high cholesterol. And then the confounders are going to be like high or low LDL, or like high LDL, or like high VLDL, or high chylomicrons, you know, and you're going to have to pick high triglycerides and high LDL. And the last thing is that when using these charts on page 2 and 4, remember that 1 and 5 have very particular presentations. You're going to be able to identify those right off the bat. Type 2As have normal blood triglycerides. That's so characteristic of them. And then type 3s are the ones that have the triglyceride counts that are like 600, 800, 1,000, just astronomical. So that's how you can tell the type 3s. And then one more time, getting down to table 2, all of the type 2As present in the same way, but they all have different mutations that will affect various parts of that LDL endocytosis pathway. And remember that when you can't bring LDL into a cell, it stays in the bloodstream. And when LDL stays in the bloodstream, as we will see when we discuss atherosclerosis, there is a really good chance that as it passes and passes and passes through the blood, the liver doesn't scoop it up. So where does it go? It just eventually finds the tunica intima of a large artery, and it says, oh, this looks like a comfortable place to lay my head. And because the liver doesn't want me, well, at least somebody does, you know? So that's what LDL does. That's the mechanism for this accelerated atherosclerosis, for the increased risk of ischemic heart disease. Then finally, know that a xanthoma is going to be a cholesterol crystal that just gets bigger and bigger and bigger and eventually gets walled off, kind of like a granuloma, you know. Know that a corneal arcus is the deposition of cholesterol into the stroma of the cornea. A-beta and hypobetalipoproteinemia present very similarly. A-beta is worse because A means total lack of, and hypo just means lowered count. And remember that A-beta and hypobetalipoproteinemia are malabsorption diseases because you need to be able to correctly produce ApoB48 in order to get fat and lipids out of your gut into your bloodstream. And if you can't do that, you've got fat malabsorption. So that's how those two present. That's about it. Thank you guys very much for tuning in and checking out this SDL. And please feel free to comment if you notice any discrepancies in anything that I've said, because I've talked a lot. You know, I'm sure that I've misspoken a few times, and it would be very helpful to me, and it would help you learn it as well if you were able to go through and say, oh, hey, I don't think that he's quite right here, and to correct me maybe in the comments or in our class Slack channel. Thank you very much.